welcome back, everybody. It's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got our usual co-host here. We got in Caleb Ferroni, and we got two special guests here. We lost half of our usual crew. We got two special guests. We got Dr. Greg Stefano, who's an interventional cardiologist here at Geauga, and Jeff Patty, who is our chest pain coordinator at Geauga as well. He's an RN. Guys, hey, thanks for hopping on, and we just want to talk about field STEMI, field recognition. What happens when we pop a STEMI in the field, and what goes on your side of the world? We want to talk a little bit about that process, and what you guys see as high points and maybe some low point stuff we can improve on. So hey, thanks a bunch for joining us.
Well, thanks for having us. This is quite a endeavor you guys are undertaking here, and it's great for education. I mean, it's phenomenal. So we're really happy to be here.
Yeah, cool. Thanks. So first things first, if I can start with you, Jeff, what does the chest pain coordinator do? Well, other than keep the docs in line.
Well, I don't know about that, but the chest pain coordinator, I'm kind of like the cheerleader of cardiology. Okay. I get to see the coolest cases, get to see the patients that are the sickest, and I try to facilitate getting the patient to the lab with the least amount of interruptions. That's sort of how I see it. So whenever possible, I try to be the first guy in the ER, scouting out the cases. I'm usually emailing EKGs to Dr. Stefano or texting him, what do you think? Should we go to the lab? And then 9 times out of 10, he's down there in 5 more minutes to meet the patient.
Two steps behind, yeah.
That's one of the things we like to do at Geauga to help expedite is a lot of times we'll meet the patient right at the EMS bay door. And whenever possible during the day, we'll take them right to the lab. If it's a true STEMI, we're going to bring them right to the lab.
Right in, yeah. And that's not unique to our system, right? No,
correct.
That's a pretty common model in UH.
Yeah, no, I mean, I think that Jeff saying a cheerleader is a little understatement, because he's actually, the quality director in a way, and ensures that we're doing the right things in the hospital, and also really is more the liaison to EMS mostly, because, I mean, it is a team effort. There's no doubt about it. We have been extremely successful at Geauga and throughout the system, I feel very strongly because of our work with EMS. I mean, now it's sort of cruise control in a way right now. But I mean, when we really started this 10, 15 years ago, I mean, doing the stuff in the field, right? I mean, it was an uphill climb, not because people weren't willing, just because people weren't really doing it, right? I mean, when we're talking about doing early meds in the field, everyone gets a little, hesitant. I mean, now it's routine right?
For us. Yeah. But I want to talk more about those meds later.
Yeah, of course we'll get there. But so really. This is a team. I mean, it starts and it's all up front, and so we have to be able to communicate as a team as well. So I mean, that's the biggest piece with all of this.
And I think it's cool that you mentioned 10, 15 years ago. It's still in its infancy, and it's progressed so much. I mean, in 10, 15 years from now, when I did this, it's been 20 years ago. We didn't learn how to look at EKGs.
Yeah, you beat me to the punch, right?
Yeah, we were looking at 3 leads maybe that were electric and just went,
yeah.
And then if you were lucky, you could print them. But we weren't. We looked for asystole. Yeah. And then, maybe VTAC and VFib, I think we were familiar with. But other than that, I mean, we were not doing 12 leads.
Yeah,
that's
25 years ago when I went to medical school, I mean, that was solely the domain of the physician, right? It's just like, oh, no. Maybe a hospital medic was trained as a tech to put one on.
To put one on, not read it.
I mean, we didn't have the tech in the field, right? Not by the tech, I mean technology. Obviously, what cell phones, wireless data has revolutionized that and continues to, right? That's been the big driver of this, what we can get out. We were just talking off air. I mean, we really expect even ultrasound and whatnot in the field here. By the end of my career, that'll, you guys will be looking at that real time with us.
Yep.
We've the data has caught up. But you beat me to the punch. It's like 20, 25 years ago, we weren't even taught this taught 12 leads in paramedic class. basic electrophysiology, and that was it.
Einthoven was a man.
Was a dude.
But no, I mean, and to your point, I mean, even now, look on the bomb squad, we have records now of what the normal EKG was for any of the members, and we're comparing them.
We trend those. We trend those real time after cases if we need to. Yeah, but I'm so glad that you stated that approach that you have to have, right, for optimal patient outcome, right? It's got to be a patient-centric approach with a team of both pre-hospital and in hospital, because I can certainly remember a time I've still periodically hear it crop up. It's like, why do I need to do the EKG in the field? They're gonna do it in the hospital, right?
Yeah.
And that just aggravates me to my core. And the good news is that slope has tapered greatly, right? I don't field that question much anymore, but that's infuriating to me. Simply from we're here for the patient, and we have to be part of the team. We have to be your eyes and ears, right?
Yep.
And to your point, most of the credentialing organizations actually frown upon. If you have a high-quality pre-hospital EKG showing STEMI in the field, if you're stopping in the ER to do an EKG, that's a problem.
Right.
You need to be bypassing the ED and going to the cath lab.
Right.
Because why would you repeat it if it's quality and you already activated? Just go to the lab whenever possible.
Yeah.
But I mean, sort of piggybacking on that before I think we get into, a million ways to go.
Sure.
First and foremost, we have a system policy where it's, you call a STEMI, call a STEMI. We're, like I said, there's no feedback, negative feedback. No one's going to be like, oh my God, that's why
bullshit.
They call it.
This
It's ridiculous. We never do that. And if, quite frankly, if anyone is, or if you get that feedback, I would love to hear that.
Yeah, we need to know about it. Right?
Exactly, because that's not, because listen, at the end of the day, if you even think there's something, just send it and activate, and we sort it out, because you never know what's going on in the lab. Giving us that little heads up, especially in the middle of the night, getting teams in. It's much better to call off the dogs, right? And I've had many discussions like, hey guys, I see what you're talking about here. I don't think this is a STEMI. Yeah. We're okay. There should never, ever be like, oh, I shouldn't send this. That is the worst thing to do.
Especially in MCIs and triage, we're always teaching to over triage the patient. This is the same thing. Yeah. And if I activate a STEMI, and like you said, one thing I think it's warranted talking about, we've mentioned transmitting your EKG. How many people are looking at that when I hit send? And we were talking a little off air about, I've heard from people who said, oh, the hospital called the squad and said, that EKG you just sent was a STEMI, and we're waiting for you, and this is what you need to be doing. And they're like, what? So that's awesome that the system's working. I tell you, it gave me goosebumps the other day at the Chiefs dinner, when you stood there and you said, we always strive for a door to balloon of 1 hour. Well, now you're looking at maybe home to balloon in 1 hour, and that's just amazing. Yeah, that's just amazing.
Yeah, and again, those kind of metrics, cannot be done with. That is an EMS metric. If you're taking
it truly is,
like home to balloon. But I tell you, we're gonna see how it goes, because I got to tell you, with how we've all worked together, there's no doubt that we're. University Hospital is going to be in the front lines of this. Yeah, sure.
Conversely to your earlier point, about even if it's an activation that you don't take action on, it's put it on your radar, because they might not be a STEMI now, but it'd be like, hey, that one you looked at 2 hours ago, right? It has evolved, right? Yeah. You already know some of the case history. You know what to do with it.
And then he's going to come in the next day and round on that patient. And he goes, I know all about this guy.
Yeah,
exactly.
Right. I took this call and. Yeah, maybe I changed my mind. Maybe there's more to do. Maybe you get another specialist involved. Yeah, there's
too. And it's like, not clear cut STEMI. Something's up. Maybe it's a dissection. Maybe it's a PE.
Yeah.
And then we're all starting then to talk about diagnoses up front.
The bigger differential.
Yeah, exactly.
No, but realistically, if you have an EKG and you're concerned, anytime you page him, he's going to call, and you're going to get a cardiologist to look at an EKG in about 3 minutes, 24/7. So that's really what our program does. All of the programs in UH do is it's a great way to get a cardiology consult in a big hurry. So when in doubt, page it out. That's what we say.
Yeah.
So.
And you know, one of the points we have on here is sometimes there's a reluctance on the EMS side of things. It's like, I'm not sure. You consult in a hurry. You can send that and just be like,
there's a great
hey,
story.
this is a mess. I mean, I feel at this point in my career, I'm generally pretty good at picking up on stuff. Does something come out on the machine sometime? I'm like, yeah, I don't know what that is. That's a mess. Let me talk to somebody that does this every day.
There's
right?
a great story about a fire
Yeah.
department that was in rehab, and the guy was coming in to recycle, and they put him on an EKG because he was just not feeling it. He's winded. He was a younger guy, shouldn't have been winded, and he had a lot of depressions. And they fired that off to one of the cardiologists who read it and said, you know, that doesn't look right, bring him in. And then later on they did another EKG and it was perfect. But because they had that, they were able to say something's not right, and things got fixed.
Yeah.
And it's just amazing that we have that capability.
Let's get in the weeds a little bit about those EKGs. So first of all, let's just hit the hot button topic for at least on our side of the table for EMS is, what do we do with those electronic interpretations on the EKG? Are they trash? They good? Do we the state put out, the state of Ohio put out, Dr. Cunningham, our state medical director, put out a rather long, white paper on basically how to trust that. Should you trust that? And what's your guys' impression on this? How often do you find the electronic interpretation right, wrong, indifferent, love it, hate it?
Well, I like it, I guess I would say. I don't know, love or hate, but I mean, I think certainly it goes back to, you have to take every patient and interpretate the data, with its symptoms and things of that nature. Because, I mean, obviously there's other things that can cause ST elevations, which is going to give you a read. But I do think in general it's a good thing because, again, it's just awareness. Now, I think for, when we're talking about teamwork and things like that, and in terms of, especially on the EMS thing, and I see this in the ER, right? The ER doc will be like, it's saying ST segment elevation, and we're both looking at it and like, okay, well, it's not. I mean, we don't see it, but I mean, at least we're talking about it. I mean, and that is the thing. So sometimes the machine can be very sensitive to maybe one contiguous or lead or things like that, but nonetheless, I think that they're fairly accurate, the reading, and it's certainly when a lot of time and efforts have gone through getting those done nationally and how they're doing it. And I do think, again, it's more of the teamwork kind of thing. I think from an EMS standpoint, everybody's always great, right? You're there and you're like, okay, I think this. I think sometimes we're, as physicians, actually, that's where we have these discussions with like ER docs, right? It'll be like, well, this is saying STEMI, and well, okay, but I don't, there's other things going on here. But I think in principle, in general, I think it's a tool we should use. I mean, and believe. Now, again, if it says, if you get a readout that says ST, segment elevation, consider anterior MI with, 4 asterisks by both sides. Okay, that's a call. But even if you don't think that's the case, again, that early call, then we sort that out. But I mean, I think that in general, it's a good thing because.
Starts a discussion,
Yeah, it just starts a discussion. Is the computer always right? No. Are humans always right? No.
Right?
And
but I'll tell you what does happen, though, is when you print that and you read it, regardless of what it says, regardless of what it looks like, when you see that, you will double look at it and you'll spend a little more time on it and say, oh, what am I missing? And then maybe fire it off your ways. The one thing I will rely on, though, is the calculations it gives. And I do love that it gives me a side of, here's your ST joint.
QTC,
and
spells it all out for you.
I do trust those quite a bit. And then before I even look at the strip, I look at the bottom right-hand corner and look at those elevations, if they're there or not, or depressions. And then I go back to the strip. And I think everybody has their own way of reading it, but I generally fold the top over so I don't get a false understanding until I make my own interpretation and then see if the computer agrees. But
and I think that's that's where Dr. Cunningham's paper was coming from, is, people that would spend no time learning EKGs, just reading an artificial interpretation, and potentially over or under triaging, because that can go either way with those interpretations, right? I know I fell into that camp. I have a belief a little more strongly about that, is I think the human should interpret it first. And at my old shop, I turned the interpretations off. It's like, no, I expect you to read this. We'll train you to read this, and then send every EKG, right? So, yeah, there's a lot. Beyond, we could probably talk all day.
I was gonna say,
I don't want
a lot of things we're just going through.
I don't want to. But it's obvious that there's still varying opinions on that electronic interpretation, and I think at the end of the day, we as EMS providers, as advanced providers, still have some onus to know what we're looking at, right? We can't just hang our hat on.
Absolutely.
One thing I would say is that I feel like whenever you guys are in the field and you're assessing your patient, and if you've got a patient with some cardiac symptoms and you do an EKG and you feel strongly, I think it would be completely appropriate for you guys to say, hey, this is a STEMI. This patient really looks terrible.
Yeah.
Like, lean on us a little bit, lean on the ER doctors, because sometimes it's on our end, it looks vague. Well, another guy with chest pain's coming in with the EKG that's questionable.
It's the story I have to paint.
Story they can't.
This guy's having crushing chest pain, laying on his couch. He's diaphoretic. He can't get off the couch.
And I think
that's a totally different story when we hear that.
Ask the medic students that we teach, and ask them, some of the first things we teach them is treat the patient, not the monitor.
Yeah.
And that's so important. I mean, it just goes a long way.
Yeah, and circling back, right? I mean, you could have, pericarditis, and that's a mild, chest pain syndrome. And yes, it'll say ST elevations on the EKG, but there's varying things. And then when you talk about how's the guy look,
Right.
Well, he's okay. It's
he met us at the curb.
Yeah,
he looks
exactly.
fine. Or he looks like trash, right? Yeah.
Or a lot of chest pain, especially when I push on it.
Yes.
Between the ribs hurts him the most.
Exactly.
So you guys are bringing up what was probably a deficit in our previous iterations of the EMS protocol, and you're going to hear this first. It hasn't even come out yet, but I do a lot of work on it. Is the protocol for 2024? There's a formal chest pain protocol, and basically the title of the entire page is all chest pain is not cardiac in nature, right? And then there's a differential diagnosis. It breaks it out, right? Could this be traumatic? Could this be from coughing, sneezing, inflammatory response? Whatever. Does it necessarily everything? If you believe it's cardiac, go to the ACS protocol and then do exactly what you're used to seeing us do today on that ACS protocol. So there was a whole differential diagnosis that we developed for 24 that'll be out here shortly. Somebody needs to make the rollout, the protocol rollout presentation like tomorrow, but nonetheless, we've to those many points, right? We've split that out. We realized that was a gap in the way we did business. All we did was talk about cardiac chest pain. So, unfortunately,
there are other chest pains.
Unfortunately, there were cases where traumatic chest pain slid off the road into the ditch, airbag deployed, got aspirin nitro.
I've been coughing for 2 weeks.
Or I've been coughing for 2 weeks.
I remember one case that was pretty funny when I worked in the ER that the patient came in, the EKG was relatively normal, but they had chest pain and ended up being a varicella rash that, came back as shingles, and it was painful and
interpreted as such.
Just missed.
Yeah, absolutely. A lot of times, obviously, all chest pain needs evaluated, as we're talking about.
Yep.
But yeah, if it's reproducible chest pain, right, that is most likely not going to be an acute coronary syndrome. So, right, it hurts, but here, yeah, of course. That's the number one thing you see. But because not everything's the classic Fred Sanford. Grab my chest if I'm coming home, and especially in women, I think that's always the toughest piece of it, because we'll we'll have one case a year where it's like, man, she didn't even. I mean, there was nothing in between belly button to ear. I remember
nose to navel. Yeah.
We had one a few years ago who's just, was like had just a little bit of dizziness. It was very bizarre. It was very bizarre. Like, because I didn't even think we had done an EKG and like. She was in the ER, and then they did the EKG, and there it was, and it was it was like, what the heck? And then, and sure enough, got her fixed up, and it went away. So, again, like, there's the chest pain piece, right? So when we talk about the typical chest pain, I think we all have a grasp on typical chest pain. That's usually a pressure sensation that's severe, radiating to your arm or your back. But mostly that's men. I mean, I think women have a lot of atypical symptoms. Now they can have that as well, and so anything in terms of abdominal pain, nausea, dizziness, passing out. I mean, these are all possible cardiac signs that we all know about, but always need to keep on our radar as well. But
I like the fact that he just rattled all that off, because now I don't have to ask him all the questions on the list, right? It was almost like you knew those were coming.
Let me ask you this. I hear so often.
I did it.
I hear so often that we'll get a strip and look at it, it's just artifact. That's just artifact. That's 60 cycle interference. And it's like, okay, maybe. How important is skin prep? Because it's one of my pet peeves that, they're an abrasive back to that electrode. Are you utilizing it? Because I had no issues with the last time I had a stress echo and then taking an EKG while I was running on a treadmill. I was moving quite a bit. Why can't we get one with a patient laying down? So how important to you as who you are, to do skin prep?
You want to take that?
Well, if you have, if you bring a patient into the emergency room and they're diaphoretic, and you've, tried 3 leads in a row, it's going to be a challenge. In that guy, you're going to have to do the best you can and try to eliminate the limb lead noise. Just put your limb leads on your side over here, and then just sort of try to eliminate as much as possible.
So you say move them up. So they're called limb leads because they're supposed to go in the limbs?
Correct.
Oh,
yes.
That's amazing.
That just eliminates any leg movement or whatever. And sometimes you can try to just take like a bath cloth or a towel and just dry them off real quick, and then 10 seconds before he starts sweating again, you try to get a quick EKG. But sometimes you just can't, you do the best you can. You try to get at least one set of leads where you could see something. In those instances where you can't really tell, that's when you got to get cardiology involved. This guy looks terrible. He's having symptoms that are traditional, ACS symptoms. He's diaphoretic. I can't get a good EKG. Can you come take a look at him? And he'll come down and, we'll try to figure it out together.
I think the important word in everything you just said was try, right?
Yeah.
And I think maybe where you were going with that is I put the electrodes on, they fell off.
So I gave up.
I can't get any. That's
Or
that's
I
so
put
not
a
appropriate.
4-lead on.
You got to take a minute and dry them off, or get your prep razor out, or do the things. Does it take an extra minute or two? Absolutely, right?
Yeah.
But that is the difference between getting you guys activated early and reperfusing this patient.
Right.
Minutes, maybe tens of minutes, or that's cellular death we're talking about.
Absolutely,
right?
absolutely. And if it's just it's usually nuisance reasoning to not do it. Quite frankly, right? But
you were going to say, I'm sorry.
No, it is important, and to find, we're not. I don't believe you guys are catheterizing infarction. It's not death. You're hoping to regain it. So most of the time, it's just ischemia, and so I kind of wish we could change the verbiage there a little bit. That it's STEMI might be ischemia instead of infarction, but I think it's important that we get that EKG as soon as we can, so that we get an early look at it, and you guys are going to trend it. If you need another one, you will, and see if there's development or. It'll tell you so much, but good positioning too. So skin prep and then placement. If it's not,
You'll
placed
probably
the same
never hear
spot.
us say you did too many EKGs.
Yeah.
Right.
Oh, I'll run 5 or 10.
Yeah.
If I'm worried about it, on myself every day. I just
'Cause I'm worried about me.
no, but I think placement's very important. If I place something, why is AVR up, not down? Well,
Yeah.
switch
You've got stuff messed up. But how many people do you see that don't take any time to even appreciate any landmarks
A lot.
whatsoever and just close enough?
Yeah.
maybe.
Yeah, well, I mean, a lot of times it could matter. I mean, it really, that's the thing. I think, you could envision scenarios where, right, if, you're trying to cut corners, right,
Sure.
and you're not truly getting out to, your lateral pre-quarter leads and things of that nature. So, yeah, I mean, I think really being systematic about EKGs is vitally important.
Especially your patients of size, you really got to take a minute to go, wait a minute.
Yeah, and you got to move some stuff around
That
and get you out.
intercostal space is way under there.
Right. Yeah.
So you
gotta go
got
hunting.
to, like you said, you got to take your time and figure it out here.
Sometimes you just need to go spelunking.
To your point about proper prep and whatnot, specifically, I mean, we've got a lot of volunteer departments. We've got a lot of part-time departments that don't have,
I know where you're going with this. That's good.
just tons of call volume, right? And that doesn't make your job any less important, right?
No, not at all.
And part of that is, of course, having appropriate equipment, and as simple as making sure that your EKG leads aren't dried out, or if you're buying
they
them
might have
pouches,
been
or
on there for a month.
They might have been on there for months, and they're all dried out, and you're not getting a good tracing. I don't know if we've had this conversation or not, but in my previous house, one of the things, hard lessons learned was, well, you just buy, save the money, buy the cheapest EKG, electrodes, and then it was just like, every EKG is trash, and you're like, and they're using 10 packs on one patient. Be like, am I really saving anything? So I think that the savings is actually in buying quality EKG electrodes to get a proper tracing the first time. And then with all that prep, and
Well,
all
we've
of that
even had
proper
some
placement.
forethought in that. What we try to do is the chest pain coordinators and many of the other people involved in the system STEMI, we made it so that you don't have to pull the leads off when you come into the lab and put your leads on. If you're using the red dots and the fast patches that are radiolucent, you won't even have to take them off when you get in the lab. You could just put them over to the table and we'll switch them to ours, because none of those EKG leads will show up on our X-ray. So we've sort of tried it. Now we've cut the amount of EKG patches in half, and then the fast patches that you use in half. And then there's always that time when you're trying to take the patient over to the table and they're disconnected and they go into arrhythmia.
Of course, that's the
and
only time they're going to have some arrhythmia or try to die on you is when the 15 seconds you have them disconnected.
Of course.
Yeah, that's Murphy's Law for sure. But not to dog on ourselves, but how often do you get just garbage EKGs? I mean, is it like a daily thing, or is it generally pretty good? What's your...
I think that I'm visualizing no. I mean, I don't know if that's filtered out by the ER. I mean, because usually the initial EKG that's submitted does go to the ERs, and I would say that 95% of those were not seeing the initial piece of that. So, but I think that we're, as a system, overall doing pretty well. At least the ones I'm visualizing that are coming through Portage and Geauga and Ahuja are pretty high quality. So
I QC quite a bit of reports and visualize those in every one of that I QC, and they're generally good. It's usually the
it's just amazing that I mean, 10 years ago, 10 years ago, you couldn't go to your iPhone and pull the LifeNet up and blow it up and look at everything from the kitchen table or the bathroom, wherever you're at. And you could just blow it up. And, a lot of times I'm calling him. I'm like, hey, there's one coming in. They didn't even page it out yet. And that's how in the know. I mean, you guys are, like I said, doing what you need to do. You assess the patient in the field. You do a 12-lead EKG. You transmit it. And even before the STEMI pager will go off sometimes, we'll intercept those. And then he knows about them, and we're already ahead of. He already starts walking over to the ER to assess the patient, and he goes, "You're about to get a STEMI," and that's pretty. He's like, "How do you know?" We know.
We know. Yeah, I know that's awesome.
I can taste it. It's in the air.
But it does. I mean, I think too. Go to the fact that these systems are in place that allow us to take care of the patients in front of you and not being, oh my God, I have to hit it right now. I mean, because I remember one case, it was like we're sitting there like, the heck is going? We're just waiting. They're like, oh no, it was a disaster getting out of there, and we could, we had to get the wife was going crazy, and and all these things. But that's why there's a 15-minute delay. They were taking care of it, and then once we had it, it was phenomenal. So I think that there's these backup mechanisms in place as well through the ECG transmission systems we have. So
let's talk about some of the alternate EKG transmission pieces. So right now, the way coming off 23 into 24, the verbiage is softened a little bit, but moving precordial leads, specifically V4R, right? If you think there's some right-sided involvement, how important is that to you guys, right? I still have to do it by protocol, right? Because my doc said so. But on the intervention side, right? Does it make a lot of difference to you? Is it happening so little that you're like, I don't even know what you're talking about? Where are we at on this?
Do I have to answer this as a board-certified interventional cardiologist?
No,
I'm joking. So I think the piece to me, a lot of times we'll get right-sided. It's like, we got to get right-sided, and I think that right-sided ECGs as a baseline are not needed, but again, it goes to the patient presentation, right? If you got a guy who's screaming there saying, man, there's an elephant on my chest, and the EKG looks normal, so maybe there is some right side. That's when you need it. But I think at baseline, I don't think we really need to do it on everyone. And that's just the fact. I think a lot of that, is overkill, and but that's what we're talking about. That is it's when there's something else. That's where I would reach for that. Right?
Your point is well taken, because in my personal practice, the only time I pull that out is if the story's there, but I got this textbook pretty EKG. It's like this doesn't match what I'm seeing here, right? All right, I'm gonna cast a little wider net, right? Also, side note. It's never yielded anything in my. I can never remember it yielding anything in my career. But
you got to wonder, like, some of these things that they want you to do. Like, is it going to take more time to do it than it? Yeah. Then should we try to spend our time going to the lab?
Yeah. And I think there's a misinterpretation of the protocol that was. And a lot of people didn't do it if they had an inferior STEMI. They held off on aspirin and heparin, held off on nitro until they did it just to confirm it. But I think the protocol has eased that a little bit.
So we undid a lot of that in 23, because the long-standing, of course, was no nitro and inferior walls, the preload and dependent, and all the stuff we have lived through. And I would imagine everybody's on the same page here that the location of the infarction yields very little on the outcome of hypotension with the administration of nitro. Are we closer? Do you see in practice other things?
I see that if you have an inferior wall MI, 2-3 AVF, they definitely are more sensitive to nitro.
Okay.
And those are the patients that, if you're hypotensive, you can give them volume.
Yep.
And then, whereas if it's V1, V2, V3, V4, V5, V6, you need to be a little more cautious with giving your patients volume. And I don't know, Dr. Stefano may disagree with me. You'd almost rather have somebody come into the lab and with some pressure, yelling and screaming, as opposed to diaphoretic and 60/30.
Yeah, clearly.
So now you treated that guy, the inferior wall, you gave him nitro, and he dropped this pressure, and now he's hemodynamically unstable. I'd almost rather keep him a little high.
Tank him up and
yeah. It's up. What do you think?
Yeah, no, I think that's exactly that's right. Because a lot of it's time and place too, right? We always talk nitro, but if you're 5 minutes from the cath lab, right, it's about getting the artery open.
Right.
So if you're having pain, yes, of course we don't want to have pain, and but we're gonna fix it. You're introducing a piece that potentially, could cause hypotension and inferior infarct. I know that there's a lot of controversy, and I could tell you a lot of times, right? I've had these calls now. It's like, the ER doc will be like, it's an inferior STEMI, and they gave nitro in the field, and okay, well, that's okay. I mean, it's not end all be all, but the pressure is okay. You know,
Yeah,
so
are they hemodynamically stable?
right, exactly. So I think you know, in the inferior MI setting, I do, you know, you'd want to not use nitro ideally all the time, but certainly I prefer nothing, you know, to keep the pressures. And it's really about, you know, getting the artery open.
Yeah, the revision for 23 was only if you had vascular access, and of course use it with caution.
Yes.
Right.
I mean,
If I were to be able to redo some of the paramedic teachings, I would get rid of Mona. Or put Mona at the back and do your aspirin, Brilinta, heparin up front.
Morphine, oxygen, nitroaspirin.
Rapid transport, cath lab activation, and your aspirin, Brilinta, heparin up front, and drive fast. That would be what I would do. And
drive quickly, safely.
Right.
LSDs.
I need that on tape. That's the part I need on tape, is quickly, safely.
LSDs, light sirens, diesel.
I hate you. Don't just go away. I don't even know why I like you.
We don't like each other.
No, not when you're bringing the LSD to the table.
How important to you are reciprocal lead changes on an EKG?
I think it gives you a lot of insight to sort of differentiate you know, some of those MI, ST elevation things we might have hit on earlier. I think that you know, it's not the end all be all that every single acute MI or STEMI has reciprocal changes, but a lot of them do, and I do think that, you know, there's a lot to be gained from reciprocal changes. I don't know. What are your thoughts on that, Jeff?
Yeah, it's sort of like one of those things. You have your two contiguous leads showing your elevations, and then you see reciprocal changes, and you're like,
Gotcha!
Exclamation point! I get it.
Yeah, well,
that's just the icing on the cake. It really, really is a STEMI. So it's sort of like a little extra push for you to take the guy to the lab.
But the converse of that is that the absence of them doesn't mean they're not a STEMI.
Correct.
Yeah. Okay.
Correct. Absolutely.
It's the what was your point earlier? It was the point on the it was the dot on the exclamation point. That's what you said earlier. If they're there, but conversely, that still could be something. Absolutely. Fantastic.
And then on the opposite of that, just remember that I know we're not talking about ST depressions.
We can talk about it. Absolutely.
But I think that Dr. Mohan brought this up, and I always remember this, is that when you have ST depressions, that does not localize like a STEMI does. So, you know, you can look at an EKG and say 2-3 AVF, probably RCA, and some weird cases it could be a CIRC. And we sort of know that by how things are wired normally. But when you have ST depressions don't exactly localize
like
it just says
that's a good point. Yeah,
there's some ischemia going on. We're not, you know, be aware. It doesn't really tell you what area it is. It just says, hey, consult cardiologist, get these guys involved.
Right.